conference. And there is one announcement before we go forward with the conference. And so I think some of you know Apta Patel is going to be leaving Duke soon. He's been in charge of research conference for the last couple of years, and he's going to be moving out west to join some other colleagues at Gilead. He's done a great job putting together the research conference and lining up speakers and so forth. But now we have a new person who's going to be in charge of that, Emily O'Brien. And so it's really good to have Emily taking this role on to think about bringing different types of speakers, different types of formats. We also will hopefully learn about her allegiance to Duke versus UNC. So she did her undergraduate degree at Duke, but did get her PhD in epidemiology at UNC. And so hopefully, especially this time of year, we'll see her true allegiance to Duke. But longer term, I think this will be a great opportunity for getting different perspectives across healthcare research and different approaches for this research conference. So let me turn it over to Emily, and I'm sure she'll have some great things to say about our speaker.
Okay, thanks, Adrian, and I'm really excited for this opportunity, and certainly if you all have ideas about speakers or formats that you think would be interesting or informative, please reach out to me, and for the record, I do bleed Duke blue, so. So today we're really excited to welcome Dr. Kevin Schulman as our speaker. He is Professor of Medicine and the Gregory Mario and Jeremy Mario Professor of Business Administration here at Duke. He holds several leadership appointments, including Associate Director here at the DCRI. He's served for more than a decade as the Director of the Health Sector Management Program, the Master of Management in Clinical Informatics, and the Clinical Informatics Degree Program, and the Center for the Study of Health Management here at Fuqua. He's published nearly 400 articles and book chapters, including publications in New England Journal, JAMA, and the Annals of Internal Medicine. He's the Senior Associate Editor of Health Services Research and a member of the Editorial and Advisory Board of the American Heart Journal. He's a recipient of numerous awards, a Fellow of the American College of Physicians, and an elected member of the American Society for Clinical Investigation. He was a voting member of the Medicare Evidence Development and Coverage Advisory Committee and the founding president of the Business School Alliance for Health Management. We are very excited to have him today, so please join me in welcoming Dr. Kevin Schulman.
Great. Thanks, Emily, and thanks for leading research conference, and sorry to you all that this is going to be the first time we're doing the alternative format. So I've been asked to give this talk a couple of different times on kind of the transition that healthcare is making. I call it kind of the pivot, and the pivot is how do we go from fee-for-service to something else, and I'll talk more about what that really means. But first to kind of set this up. Do we really have to change in healthcare? Is there any fundamental reason why what we're doing is not great, why the American public is not with us? And so I kind of start with this slide. I don't see Kevin Weinford, but Kevin gave me this great book on using, my disclosure, I'm a founder and patent holder of Viveris. I'm going to show one slide about Viveris. Kevin gave me this great book about using pictures to communicate. So I'm going to start with this picture. And this is the typical American family of four, a median income for that family. And so as you think about this family of four and their financial challenges about housing, food, clothing, education for their kids, the question is, where does healthcare fit overall in terms of their priorities? And a couple of times the room's too big, but a couple of times I ask people, like, how much do we think would be reasonable for this family to spend on healthcare? And most of the time the answer is about 5% of income. I've gotten a couple of people up to 10% would be reasonable for this family to spend on healthcare. But that's probably where we fit in terms of all their priorities, all their spending priorities. So 5% of this would be about $3,500 net, would be reasonable value for this family that if we told them you were spending this much money for healthcare, that they thought that would be reasonable. This is what we're asking them to spend. This is both the employer-employee contributions for healthcare but it's not $3,500, it's $17,000. And that's one of the huge disconnects in our healthcare system in terms of the public's perception of the value they get compared to the price. And you've seen a lot of things about the differences in prices, unit prices and costs in the United States and other markets, and I'll get back to that. But this is our first part of our crisis in healthcare, that the American public doesn't perceive the value that they are paying in healthcare. So in this graph up here on the right is this line in green is what's happening to wages in the United States. And the line in purple is the inflation in the United States over the last decade. And what you see is that the average American family wages are flat. You know, we see this here at Duke, right? We've had a couple years with no increases, maybe 1% increase. Our wages are flat. And so one of the questions as you look at our election season right now is, why are so many people so angry? And why are they so angry economically? Well, they haven't had a raise in a decade. And so people are saying, you know, the economy's not working for me because I can't make ends meet. My expenses are going up and my wages are not going up. But if you talk to employers, you don't get that story. You get a very different story. The total compensation is going up. And total compensation is cash wages and benefits. And from an employer perspective, what they're seeing is the blue line here, which is the cost of health insurance over the last decade, which has basically doubled. So that $17,000 figure I showed you was about half that a decade ago. And you have to ask the question, so what happened in the last decade? Why are these prices so high? Why are these costs so high? And it's a struggle. So we know really well things that were really expensive in the healthcare system, like our drugs, Plavix and Lipitor, all went off patent. We actually didn't do a lot of new things in the last decade. The last couple of years we started doing new things. You know, bypass surgery is totally generic. Angioplasty, totally generic during this time period. Total joint replacement, totally generic. There wasn't much new. And yet our prices doubled. Okay? And so this also begs the question, why did the prices double and how did we generate value out of that? So from an employer perspective, total compensation is going up and going up fairly dramatically because healthcare costs are going up and are such a large part of our total comp. So I've given talks like this in lots of different audiences, and I'll tell you, the presidents of Florida hospitals asked me this question. They said, you know, we're facing a crisis. Our total compensation is going up. These healthcare costs are killing us. All right? There are people running hospitals in Florida, and I said, you know, I basically was incredulous. It's like, if you guys don't find value in the services you're producing and don't want to buy them for your employees, why should the rest of us pay for it? Okay? You know, in terms of Don Berwick's Triple Aim, we have a problem with cost, but we also have quality and access issues. And I won't talk much about them today in terms of quality, in terms of variability, and obviously we're trying to do something to reduce that. But, you know, we know from Rob's slides that McDonald's gets the ketchup right 99.9% of the time, and it's very hard to find that in terms of experience in healthcare. And then in terms of access, it's really interesting to go back now and look at the Obama administration and all of the debate about Obamacare, and realize that at the end we've gone from 15% of the population in the United States that lacks health insurance to about 10% of the population in the United States that lacks health insurance. Okay? All of that we've been through in terms of discussions of healthcare over the last 5 years, that's the net result of it. And so our capacity, our political capacity to deal with some of the challenges I'm going to highlight is really limited. You know, that's the macros. And related to some of the stuff we do here at DCRI, this is a paper Brad Hirsch and I did in Health Affairs a year or two ago. Where, you know, running the healthcare programs at Fuqua, I got the opportunity to ask all the pharmaceutical companies that come in, how many $100,000 drugs can we afford? You know, what's the capacity to finance this? And they would all give me a blank stare. Like, who would ever ask that question? You know, where did that come from? And so when Health Affairs asked us to look at the specialty pharma industry, I did this graph, which they misprinted, but I corrected it here. But basically, what happens to you as an individual covered live in an insurance pool is for every 0.25% of the population that gets access to a $100,000 drug, your health insurance premium goes up by $250. Okay? Everybody in the pool is paying for these drugs. Okay? And so if you have a family of 4, your health insurance premium would go up by $1,000 for your family. And so that's where the money's coming from. When we think about Gilead and hepatitis C treatment, the prevalence of hepatitis C is somewhere between 3 and 4%. Look what happens to health insurance premiums if you cover 3 or 4%, they basically double. Now, it might be time limited in terms of that, but that's why there's such a crisis out there. I'm on the Health Policy Advisory Board for Kaiser, and basically we had a presentation that if Kaiser covered everybody in their population for hepatitis C treatment, it would cost them $18 billion, and they would basically be bankrupt as a firm. With Suresh and Shelby, we looked at PCSK9 as they were coming out, and we actually loaded the PCSK9 data into the same model and asked the question, like, how much would we all have to pay for access to PCSK9s? Adrian popped out because he knew I was going to do this. But so I asked Adrian one time, how much would he pay, without telling him the answer, how much would he pay for other people to have access to PCSK9? And Adrian said it was worth about $5. Which I used on the webinar in the New England Journal website. But this is, this is actually the amount of money we calculated that if this technology was used the way it was envisioned, it would cost. So $124 for every person in the insurance pool to pay for PCSK9 for people at high risk who didn't tolerate statins, whatever that is. We've talked a lot about generic drugs as well, and huge changes in the generic drug market, and the factors on the brand name pharmaceutical market and generic market are very different. This was literally a class discussion a year ago last fall, and these are 2 of my students from the class, where we looked at basically market failures in the generics market. And the interesting thing is to look at the companies that are involved, and a bunch of these are a company called Valeant Pharmaceuticals here, and for Isuprel. So you all should know, most of you have never heard of Valeant, but Valeant's run by Mike Pearson, who's a Duke grad. The nursing school is named for Mike Pearson's wife. The nursing school building's named for Mike's wife. And if you go to Cameron, you'd see Valeant on the scoreboard sponsoring the Duke basketball team. That won't be there next year because Mike just lost his job this week. But in terms of the generic market, there's an entirely different set of factors that are going on that we talked about in this piece. So that's kind of the private health insurance market. And then in the debates, we never talk about entitlements. But this is happening. This is what's happening to us here in this country. And basically, in 2011, the baby boomers started hitting Medicare. In 2011, there are about 46 million Americans in Medicare. By 2025, there'll be 74 million people in Medicare, and that's going to continue to grow to mid-century. Okay. Beyond that is the aging of the population in the United States, and even within Medicare. So one of the fastest growing age groups in Medicare is the old, people age 85 and above. And by 2030, we'll have 10 million people in the United States age 25 and above. 85 and above. Okay? So imagine activities of daily living, dementia, and all of the diseases of the elderly. How are we going to care for 10 million people who need this type of care? You all should know there's actually no financing for long-term care. About 1% of the United States population has private long-term care insurance. The Medicare program does not cover long-term care. And so the only public program for long-term care is the Medicaid program. And this is a huge challenge to Medicaid. Basically, people have to go bankrupt to become eligible for Medicaid to pay for long-term care. But this is all that's facing us. Actually last week, Heider Work and I did a paper in the New England Journal talking about Pfizer's tax inversion. And in the paper we said, Pfizer doesn't want to pay taxes. Well, where does their tax money go? And obviously Pfizer sells their products to Medicare, Medicaid, and the VA. And the question is, well, how much of their revenue is supported by general tax revenues, the taxes they don't want to pay? And so New England Journal actually let me publish this P&L for Medicare. Really excited about it. But here it is. In 2015, Medicare required $250 billion in general tax revenues to support the program. And by 2025, Medicare is going to require $542 billion to support the program. Basically, when you talk about Medicare, there's parts A, B, and D. Parts B and D are not funded. They're funded out of general tax revenues, and those are the parts of Medicare that are growing most rapidly. I don't have the Medicaid slide in here, but Medicaid, with the expansions over the last couple of years, is now covering 71 million people in the United States at a cost of $500 billion a year, $300 billion to the federal government, $200 billion to the states, roughly. So when we talk about entitlements, deficits, and entitlement reform, most of what they're talking about is health care. Okay? They won't, I was at HIMSS when Romney was speaking, and he said, you know, Republicans are very worried about deficits and sustainability, and we have to tackle entitlements, and then he switched gears. So tackling entitlements thinks you're going to have to figure out some other way to finance $250 billion in 2015 dollars, plus $300 billion in Medicaid dollars. One of the things that you know is the House Republican plan is basically to shift those costs in individuals to a defined contribution program. Okay. So I use those slides to make you really depressed. But it really to motivate us to say we could do better. There's no question we have the capacity to do a better job for the American public in terms of delivering better value from healthcare. All right? That's what we do all day, every day. But we're not totally focused on tackling the problem at the magnitude that I talked about. And so right now, this is Lao Tzu. You know, the difficult things of this world must have once been easy. The great things of this world must have once been small. Set about doing difficult things while they're still easy, and do great things while they're still small. It's time for us to change, and we're the group that could lead this change. And I'll outline some of the challenges that we have to leading the change and some of the ways in which we could think about what it would take to transform the system. And so where we are right now is we're trying to move from fee-for-service to something else. Population health, bundled payments, capitation, come up with any euphemism you want, but basically move us from making money every time we see a patient to taking risk in the context of actually lowering the overall cost of healthcare. Okay? There's no question that's the trajectory that we're going to be forced into by the public programs or the private market. And the question is, how do we respond? How do we respond here at Duke? How do we respond as providers? So Barack's not here, but Barack Richmond actually wrote a paper about 15 years ago about business architecture. And this is really a critical concept for us to understand. That in fact, we create organizations to deliver predictable results. Okay? Berwick's talked about this as well. Every organization is entirely designed to predict the outcomes they produce. But what this means is actually at a manager level within the organization, we know what the organization finds acceptable in terms of here, return on sales, all right? You guys know return on sales, that's our business architecture. And so anything that fits into the norm, into that business architecture is perfectly fine for us to implement. But anything that goes out of bounds, all of a sudden we set off alarms all over the place. Okay? And so a business architecture is a great convenience for managers to effectively run organizations, but a business architecture makes us incredibly resistant to change. Things are outside the bounds. We don't have rules to allow us to make decisions on. And so it has to get escalated to the top. Suresh helped me with this. This is a P&L for an ACO. But we have to recognize that right now our fixed costs most of the time determine our strategy, either in terms of the fixed costs directly or the allocation of fixed costs. With BMO, we actually just repeated last year his med school thesis where we looked at the fixed cost contributions of healthcare. And we published a paper just recently that said basically when you think about healthcare costs, when you think about costs here at Duke, about half our costs are fixed, according to Medicare cost reports, in terms of property, plant, and equipment. But on top of that, what's not reported there is something called labor fixed costs, which is how much we're spending on things like management, back-end staff, things that are not customer-facing. And I've seen estimates in literature of as high as of the other 50%, 35% of those are labor fixed costs. I got really yelled at by Bob Kaplan up at Harvard for saying that there's something called labor fixed costs. Bob is the person who came up with the balanced scorecard. But he allowed me now to say committed costs. So between fixed costs and committed costs, healthcare is at least 85% fixed. And so this is a huge issue if you start thinking about an ACO. if I start reducing the utilization in the hospital by just a trivial amount, 2 or 4%, basically that goes right to the bottom line. Okay, and we go from being in the black to being in the red very quickly because we're so leveraged as a business model. Okay, very highly leveraged business model is really great when you're making money, is really bad when you're losing money. Okay, and it can shift very, very quickly because basically you're going to still pay for all the fixed cost and fixed infrastructure here at Duke, even if no one was in the hospital. Okay, until we get a very different management paradigm. I showed this slide. Kristen, when she was a research assistant here, took this for me. But you know, you've all seen this in the Davidson building. And if you take a look at it one time when you're walking by, what you're going to see is here we're celebrating the first chairs of all the different departments at Duke. And what you'll notice is the names of the departments look really familiar. Psychiatry, medicine, pathology, microbiology, surgery. Okay. This is something unique in healthcare. We have an organizational chart that's 85 years old and written in bronze. Okay? And think about, from an innovation agenda, what that says about you as an organization. Okay? This is a huge challenge for us. Organizational structure is a key variable in terms of our business strategy. And here we've locked our business strategy in and are trying to accommodate this fixed infrastructure into what's a very dynamic business environment and business model. But this is part of our business architecture here at Duke. So what's our challenge? You know, the Boston Consulting Group talks about harvesting cash cows and investing in stars, and that's really what we're about right now. How do we optimize the fee-for-service enterprise over the next period of time and harvest that to invest in the population health group or whatever our new strategy is, okay? And do all that in the face of significant market uncertainty about when this change is going to occur and the trajectory of the change. And so think about the challenge of Gene Washington going to the board here at Duke and saying, you know, population health, everyone's talking about population health, the government's talking about population health. I want to take the money that we just made in the hospital last year and invest in population health rather than build a new building. Okay? We made money last year. Why aren't we going to make money next year? Okay? And who's going to help me with that question? Most of the time you see something like this. You see a model like this, that we're going to do some kind of ACO or shared savings or all kinds of euphemisms, one-sided shared savings, and maybe do two-sided, then we'll incrementally inch our way into capitation at the end. So I've been teaching at business schools now for 15 years, and I'll tell you this is total bunk. This is not how businesses change business architecture. That's what we're about. How do we transform the system? Okay, businesses don't incrementally change little by little in terms of inching into incentives. So if you were the head of our organization and I showed you this chart, what would it say about how we're doing? You know, are you excited about where we're at as an organization? Isn't this great? I mean, shouldn't we tout ourselves for doing a fantastic job? Should we do anything to change? Anyone want to change the business model? Okay. This is obviously the dot-com bust. All right. So one of the problems in healthcare, we've been stable for so long as an industry, we think change is linear and predictable. And as leaders of our organization, we're looking around to look at signals in the market that this change is going to occur. And I just showed you there was no signal. In arrears, we all know that dot-com made no sense, but it didn't make, at this point in time, there was no signal in the marketplace that today was the day this is going to crash. And so this is the unpredictability of the future. If we did a survey of people leading healthcare organizations about what the business model will be like in 10 years, I'm 100% confident that 100% of them will say we'll have a different business model. There's no question about that. The question is timing. Is it going to happen during my tenure? Is it going to happen next year or the following year? Okay? And here I'm really jealous of The Big Short. And you know, Mike Burry, you notice, is a physician. I'm really jealous because they knew the date. All of health policy would be really easy if we just published a date. if we publish a date in the Federal Register, in big letters, 2019, okay, that would actually transform our world because we would all know January 1st, 2020, everything would change. That would be the date, and we're going to go from fee-for-service to capitation on that date, and we'd have 3 years to prepare for it. And we'd all fight like mad in Congress to prevent that from happening, but maybe it would happen. Okay? But that's the difference. We don't know the date, and in face of that uncertainty and this idea that the market change is always linear leads to huge amounts of inertia in terms of our organizations and our leadership. And so we're not necessarily rising up to the challenge. We did actually make the New York Times, the University of Utah made the New York Times because they said they were going to reinvest in trying to understand their costs and actually reduce their unit prices. So the question is, how much would it cost? What are we talking about for Duke to go from optimized fee-for-service to optimized capitated delivery system? And we don't know the answer to that question. But I do have a student working on this right now. My bet is at least, for an organization like Duke, this is at least $1 billion investment. An investment in the new things that we have to do and getting rid of the old things, the legacy costs. Okay? Businesses don't transform unless you get rid of the legacy business models. And here at Duke, we have plenty of legacy business models that have accumulated in the last 85 years. The other challenge that we face is, as an organization, how do you manage this harvesting of the fee-for-service environment while you're doing population health? And if you think about this, in Kentucky, they have 365 admissions per 1,000 Medicare beneficiaries. So if you are running the hospitals, you would have a business plan that said, I'm going to attract Medicare patients and we're going to have 365 admissions per 1,000 beneficiaries, and that's how we're going to build the model of how many hospital beds we need. Okay? And they'll be very happy with that. Now, if we have the population health group, they're going to look to the state of Washington where they have 238 admissions per 1,000 Medicare beneficiaries. And they're going to say, you know what? As a population health group, we're going to build a business model to have 238 admissions per 1,000 beneficiaries. Okay? Now, both of those people are reporting into the same organizational structure. Okay? And our job is to reconcile those two. Can I allow two different business models to coexist like that? Should I tell the hospital to maybe plan on 238 admissions per 1,000 beneficiaries instead of 365? That's a huge challenge for us because the hospital made money last year. Okay? But the question is the hospital going to make money next year? Would you guys invest in this group? So this is obviously Bill Gates and Paul Allen and Microsoft when they were in Albuquerque, New Mexico, writing something called MS-DOS for IBM. And you think about this group as an innovation agenda. We have an innovation agenda at Duke. Even our strategic plan just came out. One of our precepts is that we're going to have innovation as a cornerstone of how we're going to get from here to there. But the question is, how does this group work in relationship to everything else we're doing? What's our charge to this group? Here are strategies that we can embody to go as an organization to move forward. With Will Mitchell and Barack Richmond, we mapped these out. These are generic strategies that firms can adopt to innovate, to change their business models, to change that business architecture. We could use internal exploratory environments. We could create little project teams like DTMI and assign them the challenge of coming up with innovative new business models. We could actually do venture capital. We could actually make investments not to get necessarily just financial returns, but also to learn about how all the startups in the American underground are recreating the healthcare system. We could do acquisitions and partnerships, not of horizontal businesses, but of new businesses that we can migrate into. Blue Cross Blue Shield, you might know, reorganized about 2 years ago, and a third of their business is now called Mosaic, which is an investment arm to try and migrate Blue Cross Blue Shield out of insurance and into new businesses. Organizational design is a key element of strategy, and Clay Christensen in The Innovator's Dilemma talks very specifically about Hewlett-Packard and the printer division at Hewlett-Packard. So Hewlett-Packard owned the entire LaserJet printer market, and someone came up with this inkjet technology. And the idea of the inkjet was and when it first came out, it wasn't very good. Yes, it was color, but it wasn't very good as a printer. And so Hewlett-Packard had to figure out where are they going to put the inkjet team, and they put the inkjet together with the LaserJet, and they called it the printer division. And so what happened was the inkjet people kept coming asking for money, and everyone said, well, the inkjet thing's a toy. It's never, we have this huge billion-dollar printer business in terms of laser jets. Why should we invest in inkjets? And fortunately, at the time, Hewlett-Packard management recognized that this was an issue, that in fact the laser jet people were going to kill the inkjet technology, and they were going to get disrupted by somebody else. So Hewlett-Packard picked up the inkjet, moved them to Idaho, and said their job was to kill the laser jet division. Okay, and that's why you all have inkjet technology now, and not. But that was an organizational design issue, an organizational structure. If population health reports to the hospital, the same thing's going to happen. Okay, the hospital is not going to invest in things that keep people out of the hospital. Okay, that's not going to help their P&L. And then finally, restructuring and bankruptcy. This is really kind of critical concepts. Restructuring is getting rid of legacy business models. All the things that helped us support a fee-for-service business model that we don't need anymore in a capitated world, we have to get rid of. Okay? That's restructuring. And then bankruptcy is the other side of that, which is actually a legal mechanism that we could do this around contracts. Now, healthcare has driven a lot of companies to bankruptcy. If you think about the airline industry or the car industry, why did they go bankrupt? Most of the reasons why they went bankrupt was because of retiree health benefits. Healthcare drove GM bankrupt. Healthcare drove the airlines bankrupt. Okay, that was bankruptcy. They got out of it. And then we have our innovation concepts. We can ask Bill Gates and Paul Allen to tackle these problems that we were all talking about. Analytics, technology, patient engagement, population health, and personalized medicine. And there's an opportunity for us. Here's the agenda. Okay, here's the tools that we have in terms of core business strategies. Here's the things we need. And if you actually tackle these things, we can migrate our business model. In terms of analytics, this is our 5-bubble model. There's a 6-bubble model, and Kaiser's got a 7-bubble model. But analytics is not actually a solution. In the business context, we have business problems that analytics can help us solve. Okay? And for Duke, this is a huge organizational challenge. Okay? Analytics is not a technology issue. Analytics is saying, here's a business problem. Okay? Business population management. Okay? That's the business problem. And the question is, how does data help us answer that business problem? And then how do we get faculty, staff, and quantitative folk around the table to figure out what are the methodologic solutions and approaches we could take to solving that business problem? But you have to start with the business problem. You can't start with analytics and say, I have a hammer looking for a problem. Okay? And so actually we had this chart, and then I went to Kaiser's annual meeting, and we met with their CIO, and they had 7 bubbles. Okay? And they actually had independently, and actually before we, long before we did, came up with exactly the same idea. The analytics to Kaiser is a strategy issue, a business strategy issue. Technology supports it but doesn't drive it. In terms of technology, I use this slide, actually I'm teaching this slide Friday, of business process improvement, and this comes from Ted Shortliff. This is how technology is supposed to work. We are supposed to articulate what our business processes are. All right, that's how we do business in that environment of that production engine. And then look at how technology supports us doing what we're supposed to do. And then we're supposed to articulate where we want our business processes to be, and then it's very easy for the technology folks to accomplish that. Okay? And that's how you do strategic planning for technology. The only problem is it's not how we do it in healthcare. So how many of you ever heard the idea of a business process before? Okay? That's about as many people in healthcare as understands what business processes are. And so if you go to the cardiology division and ask them to articulate what their business processes are, you're going to get really blank stares. Okay? The cardiology group has not been told that as an organization they have to unify around a standard set of business processes. Okay? So what are the technology folks supposed to do? If the clinical folks can't figure out what their business processes are, the technology folks are actually tasked with trying to divine what they think the clinical business model is. Okay? I met with Asif Ahmad for a long time, and he kept telling me if the endocrinologist would, my job's not to beat up the endocrinologist and make them come to some consensus agreement on what they want to do in terms of taking care of diabetic patients, but if they would just come up with a plan, then I can implement it in technology. And so underneath technology is this idea of architecture. And it's a great metaphor. So imagine now that you're the chief technology officer here at Duke. And I can't tell you what my business processes are, and I want you to build technology to support it. Okay? So imagine that person's now building a spec house for a very demanding customer. Okay? And in fact, we're going to yell at them a lot if they don't put the right number of bathrooms in the house. How many bathrooms are you going to build to make sure that you don't yell at them? Okay? A huge number. Okay? So we're going to totally overbuild the technology just so we don't yell at them. Imagine that they were brilliant. If it was Steve Jobs that was the chief technology officer, and he could really guess what our business processes were, his problem is not that the technology is not right, but he actually can't compel you to follow the business processes. So even if we automated the business processes exactly, we'd have a huge challenge here. So in healthcare, we don't have this discipline of understanding that we have to articulate a business model and build technology for it. So instead, we spent $500 million and bought someone else's set of business processes, and that group is called Epic. Okay? So we sold to Epic, or bought from Epic, our whole strategic planning process and all of our business processes. And so we're now locked into not our business processes, but Epic's business processes. And this is a huge challenge for us going forward. I don't know if any of you were at Rob's think tank hepatitis C meeting, but this is a slide I showed. So we're talking about patient engagement, population health, and meeting the consumer where they're at. And I made up this slide, and I told so it was the leaders of Rob's cadre of hepatitis C folk, and we were talking about patient engagement, and I showed this slide, and people spent an hour talking about which segment of the population mapped into which group in terms of these names of the commitment ladders and qualifiers. And then I had to remind them 4 different times I totally made this up. Okay? So this idea from marketing, the idea of segmentation is second nature. Okay? There's no such thing as a population health program. Okay? We have very different segments of the market that we're agreeing to take care of. If you say we're going to take care of 10,000 people, and some of those people will respond to Kevin Volp's behavioral economics, and some of them won't. It's not that behavioral economics is bad, that's just behavioral economics works for one segment, and then we have to figure out what's going to work in the other segments. So I went to Kaiser again and asked them actually with 10 million covered lives, we can actually begin to build the methodology for understanding market segments and then begin to do approaches that are specific to each segment. This is my commercial interest. So this is transforming the patient experience. This is the technology we developed to get real-time feedback from patients about their care. We're using this at UNC. It's at Johns Hopkins in the outpatient. It's at Texas Oncology. It's not here at Duke for lots of reasons, innovation being one of them. This is a really interesting concept of actually a positive approach to building a different type of patient experience by giving people actionable feedback. And the other interesting aspect of this technology is we can identify mentors. So when I've been teaching at Harvard for the last 3 years in the business school in the fall, and they videotape my class, and then they go and review that videotape for them, and then they sit down with me for an hour and go over 3 strengths and 3 opportunities. Okay? They never compare to my peers. It's not how do you do in class compared to Clay Christensen or Reggie Hertzlinger. It's how do I do compared to myself. Okay? Here's my strengths, here's my opportunities, here's my action plan. And it was great. I mean, it's wonderful. It's great to get the strengths. It's not really fun to get the opportunities. But I sat there and I finally told them, I said, you realize I'm really glad you guys care about the experience of students up here at Harvard who are incredibly coddled and well on their way to wherever. But as a provider for the last 20 years, I've never gotten feedback like this. We get no feedback whatsoever at all. Can you imagine if you're having an issue with patient experience? I could tell you, compared to your peers, you don't explain why you order a diagnostic test. Let's just work on it for the next quarter. It's just a communication issue. Let's build your communication skills. And not only that, it turns out Dan's really good at this. So next time you're in clinic with Dan, why don't you pop your head in and see how he's doing, how he does it. Okay? It's not rocket science. It is not punitive at all. It's all proactive and positive approach. What? So population health is the next of these innovation strategies, and the issue here is to try and find the high-risk group of patients. And so if you think about a population, a typical insured population of $3,000 per person, and then we map them out. 85% of people, or 85% of the population, is really going to have almost no utilization, about $900 per capita. And then 15% is going to use 70% of the cost, which is basically what you find in every model. 1% of the people are going to use 25% of the cost. And so your population health strategy is something akin to trying to identify these different groups of really high utilizers, the people at an average cost of $65,000 compared to $20,000, compared to $7,500. Not spend a lot of money on people who are only going to cost you $900 a year. And then the other question that's totally unknown with any of this is how much of this cost is avoidable. So Mike Pensina can do a great model and predict the cost of these different buckets, but that doesn't tell me that these costs are avoidable. Okay? And so for population health to make any sense, I have to predict people into buckets of avoidable costs, and that's a huge opportunity for us. And then personalized medicine, and this, actually, Anna, you're on this one, I think. Yeah. Actually, we looked at this. This is actually a paper about 10 years old now, and looking at some of the issues around personalized medicine as an opportunity to disrupt the healthcare system and some of the challenges there. So I've gone over the models, the business models we could use for our innovation agenda, and the things that we could get these people to work on, but how does this innovation agenda fit with our production engine? And there's this great book, The Other Side of Innovation, Solving the Execution Challenge, that really details and documents the challenges that this faces for an organization and organizational leadership. And basically, if we task these guys with playing with the robots on the production line, we're going to fire them in a week, right? There's no way that we would allow these people to tinker with the robots on the production line, okay? That's going to kill us as an organization. And so how do we solve this problem that we have this innovation agenda? We want these people to innovate. Who doesn't want Bill Gates to be part of your organization? And yet if we set Bill Gates loose on what we're doing on a daily basis, we're going to fire him and kill ourselves. And so Larry Page actually helped us. And this is Larry Page. This is what Larry Page is trying to do as the leader of Google, now Alphabet. He wants to get more ambitious things done. He wants to take the longer-term view. He wants to empower great entrepreneurs and companies to flourish. He wants to invest at the scale of opportunities and resources they seek, improve the transparency and oversight of what they're doing, making Google even better through greater focus, and hopefully as a result of all of this, improving the lives of as many people as we can. If this was our mantra here at Duke and say this is what we were trying to accomplish, we couldn't be any prouder. And what did he use all these words to describe? An organizational restructuring, where he broke Google up into independent units and called them Alphabet. Okay? So here is the most innovative company in the country restructuring as a way of promoting innovation to try and address this challenge of the conflict between the innovative groups and the production engine. So now we have to go back to ask the question, a basic question that I started with. Why are our costs so high? Why is healthcare so expensive in the United States? Clay Christensen in The Innovator's Prescription maps out some issues that we have to grapple with. Mission complexity, facility complexity, and obviously here's a map of our campus. Process complexity, management complexity, business process complexity in terms of third-party payment. Every time you see the word complexity, realize there's a manager behind that to help you manage that complexity. And at Duke, we have 4 different managers, and their job is to fight with each other to help us manage this complexity. Okay? That all adds costs. So we have 4 organizational structures in parallel. The School of Medicine, the PDC, the PRMO, and the health system, all of whom have management infrastructure to help you solve the same problem. And that makes us a very expensive business model. Okay? That's our cost, but why are our prices so high is an entirely different issue related to something called market leverage. Here's Jamie Robinson from Berkeley. In California, if you go to a doctor that owns their practice, you cost your health insurance company $3,000. If you go to a doctor that practice is owned by the local hospital, you cost your health plan $4,300. And if you go to a doctor whose practice is owned by a large health system, you cost your health plan $4,700. Okay? you're paying $1,700 for the privilege of going to a physician's office that has a nice logo on the door. Okay? In terms of value add, why is this the case? This is all market leverage. This is a very specific business plan that hospitals have been following since Hillary was in the White House. So Hillary told, basically, go back to 1993, Hillary's model was, we're going to get doctors and health plans to beat up on hospitals. Okay? That was Hillary healthcare reform in 1993. The hospitals got the message that they didn't have a lot of leverage against the health plan. And from 1993 to 2008, hospitals were really busy acquiring each other. Okay? It's no secret in 1997 we bought all the hospitals in Durham County. Okay? That was a great business model. If we were a for-profit company, that would have been totally anti-competitive, and the Justice Department would have thrown it out as an antitrust violation, but we're not for profit. The University of Pittsburgh bought all the hospitals in Pittsburgh. Okay? This is how successful this business model was. Actually, just this week, Lee Moore Daphne has a new paper out showing what happens when hospitals acquire hospitals even in adjacent markets within the same state. Like Carolina's Healthcare has been doing, the unit prices for those hospitals go up by about 10% in the first year. Stu Altman's been down here, and he's the head. Stu Altman is the co-chair of the Health Policy Commission up at Harvard, up in Boston. But basically, after Romney Care, it got put in place, Romney Care didn't do anything about healthcare costs in Massachusetts. So Deval Patrick, as governor, was in a constant fight of trying to reduce healthcare costs in Massachusetts. And what he put in place was this commission with Stu and Dave Cutler to try and improve transparency in Massachusetts on contracts between health plans and providers. One of the first contracts that this group had to look at was a proposal by Partners Healthcare to go buy a hospital on the south side of Boston. Stu's group looked at it and said basically the net impact of this thing was going to be a 35% increase in the unit prices at this hospital for no change in cost or outcomes. And the Attorney General of Massachusetts filed an antitrust suit. And then we talked about in the New England Journal about some of the processes. So basically this proposed settlement got thrown out, and then Partners is now backed off. And so Partners, if you talk to your friends up there, is totally landlocked now. They're really precluded from doing any more acquisitions. And so now they're in this really unique position of trying to figure out how to manage their business. The payers haven't been quiet in all this. In the market, the health insurance market's changed, and it's changing fairly dramatically. And so this is Kaiser Family Foundation data. Basically what you see is a huge shift to something called high deductible health plans, which are now about 24% of the market. And it's an employer-sponsored option. A high deductible health plan usually comes with something called a health savings account, but we're using these plans in the exchanges as well. And there you don't have a health savings account, so people are complaining that they don't have the money for the deductible, even if they're covered under insurance. We talk about the public exchanges, but we looked at the private exchanges a couple of years ago with Barack and Reggie Herzlinger, and basically private employers are trying their own private exchanges. And this is the results from 2013. 42% of employees purchased less expensive plans, 32% bought the same coverage, and only 26% bought more expensive coverage. And so when people have the option to buy cheaper plans, they will because they don't see value in health insurance. But also, more importantly, that money is money that's moving out of the healthcare system and most likely is not coming back. The other strategy that insurance companies have adopted in the face of these prices is something called narrow networks. And so here the idea is that we're going to get Duke and UNC to bid off each other and say, you know what, only one of you can stay in network, and this is the 1990s all over again, we're going to give you market share in return for price concessions. Okay? And so that's narrow network. And obviously that happened in our market, so you might remember in the fall we were saturated with this idea, is Duke in your plan? Because we've been narrow networked out of a couple of plans given our unit prices. This is Blue Cross Blue Shield's data estimates for Cabbage in North Carolina, and what you can see is we're 20% more expensive than what UNC was able to offer. And so you have to ask the question, is our Cabbage 20% more valuable to individuals? Is it worth, in this commercial, is Duke in your plan? That's great. Is Duke worth 20% more to be in a plan that has Duke than somewhere else is a different question as a consumer that we have to figure out the answer to. And then charges, this is a charge for an angioplasty. So for a one-day stay at Duke Hospital with actually MPO before your procedure, it would be $70,000 in terms of hospital charges. And this is a whole nother issue with Barack that we looked at a couple of years ago, and Mark Hall from Wake Forest. And so some of the issues, some of the questions is why do hospitals get charges? And we asked this a couple of years ago as an independent issue, but now it's actually a critical issue with narrow networks. Because the retaliatory strategy, if I've been narrow networked out, is say, fine, just make sure your patients don't come to my emergency room because I'm going to hit you with charges. And in this article, we actually go through the legal basis of asking the question whether or not the hospital has any justification for charging you charges. We have another paper in the American Journal of Managed Care, hopefully, that will come out and look at this in more detail. So either way, it's $60,000 for bypass surgery in the United States. Is that good value? Are we doing a great job at doing bypass surgery? And this is CARE Hospital in Hyderabad, India, and this is a paper we wrote a long time ago. But basically, this was Bill Hazeltine, who was running Human Genome Sciences at the time, brought Kirsten Reddy here to Duke to talk about his development of this hospital. This is a for-profit hospital in Hyderabad, India, that does bypass surgery for $2,500 a case. Okay? So there's lots of difference in wages between the United States and India. But in terms of are we doing a good job and are we creating value for individual consumers, we're a log order higher prices than what is possible out there. So in terms of business model innovation and solving this problem for the American consumers, solving this problem in terms of price, I throw this out there. What if 50% of healthcare was delivered by mHealth technology by 2025? It's for us right now to think about technology. Why don't we say, why couldn't we do this tomorrow, right? I mean, there's nothing that this technology, no technology that's required to do this that's not available today. This is a whole business process issue, whole organizational transformation issue. Actually, Judy Kramer and I talked about this in a paper for the Institute of Medicine a couple of years ago on clinical trial research costs. But basically, what would be required would be for us to transform our business model. And then we could actually redesign the system that said, you know what, I could take care of most of my healthcare needs, especially the 85% of the population are spending $900 a year. They could do most of their stuff by cell phone. Okay? You never have to have bricks and mortar. You never have to see them in person. And in fact, if I needed someone to look in your ear and you didn't have a little ear camera on your phone, then I could send you to MinuteClinic or Target or Walgreens. And if you needed something more complicated, then maybe I'd send you to an ambulatory site. And if you needed something more than that, then maybe I'd bring you into a day surgery or maybe even to the hospital. But the hospital will not be the first resort, but the last resort. We've talked a lot about clinical workflow. And one of the issues with technology is to think about how to embed technology in a clinical workflow that makes sense. And this is Philips VisiQ. Brian Rosenfeld did VisiQ and is still running this project for Philips. But basically, they're going to use technology to try to move people out of the hospital and into the home. One of the other dilemmas we have to solve is Craig Christensen's, this dilemma from Craig Christensen. In the computer industry, he talks about decentralization and decentralization of the computer industry as a way of how we got from the mainframes to the iPhones in your pocket that probably has as much computing power and definitely more memory than any of the 1970s models computers at a fraction of the cost. Okay? And how did that happen? It wasn't the mainframe makers that made your iPhone. Okay? The industry decentralized over subsequent generations of technology, but also of business models. And that's why now when you buy a computer, you go to the Apple store or the Verizon store and not to a dedicated computer facility. In healthcare, Clay says we're going to do the same thing. We've decentralized everything in the hospital, and so now from a consumer perspective, we want to decentralize in order to get better cost and value out of the healthcare system. And one of the questions, and I went back and forth with Clay at this at a meeting at Harvard, is who's going to lead that decentralization? Are we going to charge Duke Hospital with decentralizing the healthcare system, or Duke University with decentralizing the healthcare system? Or is this something where independent organizations are going to have to come and disrupt this market? Suresh and I mapped this out of an innovation agenda here at Duke, and you could easily imagine an innovation agenda around technology, services, around business models, around policy. For most of my career here at Duke, the idea of innovation is innovation that Duke owns. As an organization, we own all the innovation here at Duke, and we're not doing much in terms of innovating. If you go to where Bob is now at Stanford, he's surrounded by all this innovation that's spun out of Stanford. And Stanford's job is not to own the innovation, but to empower an ecosystem of innovators. And so the question here at Duke is, which model do we want to pursue? Do we want to continue to pursue we own everything, or do we want to imagine Duke as a place that enables this kind of innovation that we're going to see in the marketplace and benefit in that way? So, this is a really open question of how do we innovate to build our future. And it's a huge opportunity for us and a huge challenge because of whether the organization really is going to move in a new direction to tackle these changes. Is this market change that I talked about real? And is there still time for us to get ahead of all of this? So thanks very much and happy to take questions.
We have time for one or two questions.
Yes, Neil?
Kevin, that was terrific. It seems to me that the issue around delivering healthcare is in some ways relatively simple, which is that the key players are incentivized to maintain the status quo. So for example, I work at the VA and at Duke. We have a very robust telemedicine program at the VA. We don't have one at Duke. Why? Because I can't bill for it. So, if you've got a hospital or a health system that's making a $300 million margin every year, what is the incentive to actually change that? Similarly, one of the reasons that costs are so high is that we allow companies to charge whatever they want for their products because it's written into law that Medicare Part D cannot negotiate drug prices. The VA negotiates all drug prices. So the same drug that costs $1,000 at Duke, you walk across the street, it's $100 at the VA. So it seems to me that there has to be some kind of political will to change the incentives that are inherent in the system before you can actually have some kind of transformation.
Yeah, well, at some level, you're absolutely right. In 2009, we asked the federal government to do something different about healthcare, and we got Obamacare. And so this is the business school side of me speaking. Thinking that the government's going to be the engine of change and innovation, you got as much innovation as the government can do. And now look at where we're at in terms of political process. So we can't look for help. I was at the Connected Care Conference at Harvard, and one of the leaders of MGH's clinical practice talked about the cost of healthcare and complained about the high cost of healthcare in Massachusetts. And in fact, it was such a crisis that his daughter's elementary school had to lay off one of their teachers so that they could cover their health insurance premium. Okay? Why are healthcare costs so high in Massachusetts? Because of Partners Healthcare. Okay? The guy was going back to work, putting his daughter's teachers out of business, and didn't reconcile the two. So he actually was the one who came up and said, well, the government has to help. And the government's not going to help. We're going to continue this as a Chinese water torture of people ratcheting down if we don't take action. So I think there's an opportunity, and this is where leadership comes in. Yes, we made this money last year. Yes, we may make this money this year. What are you going to do with the money? Okay? You can sit on it and hope that nothing will change, or you can sit on it and bank it until the market really shifts, or you could shift the market. And I think those are strategic choices available to us.
One more quick question.
Dan?
I don't know that I can ask a quick question after that talk, that's a fantastic talk. And as soon as I get my Prozac prescription refilled, I'll think of my question. But I think you accurately captured the incredible complexities of the problems that we face. I don't see, short of everything in health policy that has been transformative, I think, and perhaps in the larger economy, tends to follow some sort of a crisis. Or Clay Christensen's idea of disruptive innovation is great, but it's descriptive. It's not you can't intentionally you can be disruptive, you get arrested for that, but to be disruptively innovative is not something that you can necessarily do as, I want to be a disruptive innovator when I grow a career. It just, you have a great idea, you pursue it against all odds, people try to talk you out of it, and you still manage to get it to happen. And so somebody somewhere perhaps is coming up with an idea to destroy healthcare as we know it and build something else. But Ken, you know, are we like the people at Hewlett Packard and DEC Computers, and we're just sitting around here waiting for for somebody to put us out of business? But it's not going to be us that actually leads this.
I think that's an open question. So I realize one of the slides not in here is the organizational response. Okay, you know, why is it? Look, I rhetorically say, you know, it's $70,000 to spend a night at Duke Hospital. I'm sure the bed's really comfortable, but you can go to the Four Seasons for a lot less than that. Why don't we just put a Four Seasons across the street and take care of people overnight? And so there's no question, if the market's going to shift, we could either shift with the market and change as an organization in anticipation of that shift, or we could just wait and be roadkill. And I think some organizations are going to do one strategy and some are going to do the other. You know, for me, you know, we have, you go back to the, you know, a Jew doing the Bible, but, you know, you had 7 fat years and 7 lean years, right? You know, you don't sit here with the fat years and say everything's rosy in the wake of all this coming and think we don't have to prepare for the lean years. You know, I think it's really hard as an organization to get in front of all of this, but that's why I do the slides at the beginning. Right? There's nothing about this that's not going in this direction. That there's not the money available to support the healthcare system that we have today going forward, and it's a real question about whether or not we believe that and want to do something about it, or we just want to wait and see what happens.
Can an individual institution actually act in this context, or does it have to be part of a movement?
Well, you know, so one is, during the election, we talked about 6 high-performing healthcare systems, right? Kaiser, Mayo, Geisinger. I mean, little Geisinger. We talk about Geisinger all the time. All right, so people can make choices. Those organizations have made choices that allow us already to identify them as high-performing organizations, okay? And then that could get other people to actually take action. So at a national level, you're absolutely right. And the question is, at a local level, can managers make different choices? And the answer is absolutely yes. Most of them don't. Most of them don't bother, but some do.
Great. So that's all of our time for today. Thank you very much, Dr. Shulman, for an informative talk, and thank you all for your attention.
Thank you.